It's a great pleasure to be here to participate in this important virtual conference, an annual conference. And I'm Mike Farkouh. I'm an epidemiologist, clinical trialist at the Petermont Cardiac Center in Toronto. I want to talk about the INTERACT, which is the International Registry to Assess Cardiac Tumors. Obviously, this is a labor of love of many people and is an evolution, but I wanted to present some of the most important aspects of this. So primary cardiac tumors are rare, about 0.02% of autopsies, and they involve about a third with myxomas, a third with other benign tumors, and about 25% are malignant tumors, is well known to the group. And there are secondary cardiac tumors as well, which are more common and are usually arrived at a disseminated stage and are often overlooked. And we'd like to chronicle the outcomes of cardiac tumors in a way in which we may inform future clinical trials that may be embedded in registries or maybe standalone clinical trials based on the evidence. Over the last 4 decades, there are many published cohorts, but no single institution has the ability to report on large enough numbers in order to really impact and change practice. We need to all come together to bring our experiences on the surgical treatment of tumors and the medical management of tumors in order to better understand prognosis and management. So what are the knowledge gaps? Well, what is the best way to treat specific tumors? What is the best surgical method? What are the centers of excellence? Should we have true centers of excellence that operate, or should it be more widespread and more of a groundswell? Are there different patterns of disease in different parts of the world? Are the genetic differences playing a role in how tumors present in different parts of the world? And again, we need an international consortium. Even a national consortium, even in the United States, would not be large enough to be able to answer the questions that we've listed above. So INTERACT is a multinational, multi-center registry with the aspiration to gather enough data and to create a platform for investigators to interact and conduct clinical trials in order to answer the aforementioned questions. Now, the folks at Methodist have used REDCap to design their registry. It's actually fantastic. It involves the demographics, the patient history, the baseline tumor, the chemotherapy that's used, radiation therapy that's used. They also have operative details, including time from initial recurrence, and the pathology as reported. There's a biorepository, allows us to go back and analyze biosamples. And then, of course, the follow-up of the patients, including for death, recurrence, and time to recurrence. So we really are going to stand on the shoulders of others, and the folks at Methodist have done a wonderful job of putting together their registry. I think we can adopt many aspects of this into INTERACT and use REDCap potentially as our platform. This just shows you how it looks on the screen, how it outlines the demographics, the history, the baseline tumor, the therapies, and the follow-up. It is very user-friendly. So I wanted to introduce this because I think that we have the opportunity to really leverage the experience at Methodist in Houston with regards to the management of tumors. The IRAD model is a model that I think we should adopt. As I mentioned last year, this is the International Registry of Acute Aortic Dissection. Acute aortic dissection is also rare. It's about 2 to 3.5 cases, 2 to 3.5 cases per 100,000 people. IRAD was created to assess the etiologic factors, modes of presentation, clinical features, treatment, and hospital outcomes of patients with acute aortic dissection. It is truly multi-centered and international. You can see the various international centers on the right, the American centers on the left. These are 30 large referral centers in 11 countries, and this was established 25 years ago. The coordinating centers at the University of Michigan Health System, and they currently have data on about 4,000 patients with 79 investigators. And here is the PubMed search of IRAD publications. Last check, it was about 150 results on PubMed, and you can see consistently from 2000 to 2020, consistent productivity. So I think we have an opportunity here to really leverage our strengths, come together with a single international platform with a steering committee and a planning committee that represents all constituencies, including oncology, cardiology, cardiovascular surgery, epidemiology, and so on. And I look forward to working with everyone and Dr. Cusimano and Dr. Reardon to make sure that we can really hit this out of the park. I think having one large registry will lead to many, many opportunities and ultimately to prospective studies that will inform practice. So I'll stop there and pass it back to Dr. Cusimano. Thank you very much.
All right, thank you very much for that update. COVID has slowed us down a little bit in terms of getting this off the ground as quickly as we wanted to, but believe us, there is still very strong interest in this throughout the world. One of the questions that came in actually is a very interesting question. Someone asked, is rhabdomyosarcoma still on the rise? It is more common compared to myxoma. And that's exactly one of the questions that we have no idea about. We have no idea about it throughout the world. We have no idea about it in general. And that's what a tumor database like this is going to help us to answer. Mike, do you want to say anything, Michael Farkouh?
No, not really, RJ. I think we're in good shape to go forward. I hope that there's interest. We are really been really curtailed a bit because of COVID, but I do think that we have participation that's global, and our steering committee will go ahead with deciding on the right platform, and I think we're ready to get started. So I think we can answer many of these questions as we go forward, and we should be as inclusive as possible with regards to specialists, including obviously the cardiac surgical community, the medical community, the cardiology community, medical oncology, and the community physicians and health officials of different countries, so that we can really make a big difference. So we're excited, and we hope that that excitement is shared by others.
Yes, and a comment made by Dr. Seidman about pediatrics as well as adults. It'd be nice to have everybody join in, and we can learn very much more information than we know now. You know,
absolutely, and that's obviously implied when we say surgeons and cardiologists. But I think a special reach out to the pediatric group would be wonderful and important.
The treatments that we have for cardiac tumors, it seems to be pretty well mature. Dr. Reardon has been a champion about this in the world. When you look at the data, however, the data is not very big, because even though he has the biggest experience in the world, the total number of cases is low. And our oncology colleagues are treating sarcomas the same way they treat soft tissue sarcomas, and that may be reasonable, it may not be reasonable. And the treatment options that we have for people, and you'll see general treatments in previous years and in this year when we speak about a general approach to things, are based on small numbers when it comes to the heart. So we have a lot of catching up to do in the cardiac world to catch up to the oncological treatments in other sarcomas, other tissues, other types of tumors. So a international database like this is extremely important for our understanding and pushing the whole treatment of cardiac tumors forward. Mike Reardon, you want to add to that?
No, RJ, I just thank you and Michael, for helping organize this database. I mean, when I first started this about 2.5 decades ago, I'd have patients come to me and they'd tell me, well, my doctor saw me and took an image of my heart and just told me to go home and die. And they literally, nobody knew what to do. And I think we've slowly been building this kind of national, international network of people interested in this so that we can move this forward. We still have a long way to go, particularly with malignant tumors. But it is nice for people to understand that there are options out there as long as they come to centers where they have heart tumor teams that can look upon this in a multidisciplinary fashion.
Yeah, that's right. Even if they have a place on the internet, a presence, they can contact us, and we can send them to a place that we know about. The problem is trying to find those other places, and that's one of the goals of a cardiac tumor database. It's really very, very important, I think, in moving forward in the future.
RJ, I think that's a really important point that Michael raises and alludes to the fact that as we do this, as we perform this registry, we're going to have patient engagement and patient representatives from societies and patient care groups, patient groups, to be part of our steering committee and help guide us as to how we can address patient-related issues. This is very important as we work with U.S. and I know U.S. and Canadian federal agencies, and that we seek funding as well, that we have patient engagement on our steering committee and in on our particular working groups.
I'd also point out, RJ and Michael, that for the young academic physicians on the call, like you point out with our IRAD, this is a potential gold mine of academic presentations, publications. And when I started this 2.5 decades ago, I thought I'd write a paper or two, and it has been very academically productive. And of course, the best way to be academically productive is get big data. And so this will really help us.
Michael, your database, how large is it now? How many patients, and how user-friendly is it? Is it something that you believe we should build upon, or should we create our own infrastructure? You know, I really think your database is comprehensive and yet pragmatic, and a pragmatic approach. Just wondered about your thoughts about the current database that you have.
Well, I have about 450 total cardiac tumors. I just had an abstract accepted to AATS of, I think I'm up to 135 primary cardiac sarcomas, and that's going to be presented at AATS 2021. So we have a fair number. I mean, I think our database is easy for us to use. I think the main thing, Michael, we want to avoid is getting multiple databases that don't speak to each other. And I think it's more important that we standardize than which particular database we use. I mean, you know, there's a number of good databases out there. But, you know, we want everybody, just like IRAD, putting in the same clinical report forms and data. And if we get that, then we're going to be in good shape. But if we start 3 different databases in 3 different centers, that's going to be problematic.
You know, no question. And I guess the other major question is the ability to transpose and bring your database into the, you know, bring whatever's existing into the current platform. And I think that's something we have to consider, RJ and Michael, as we go forward. But we're really at that point now to look at bringing our data management people and, you know, have a pitch and see which is the best system. And it may be a hybrid that we create de novo.
Yeah. And as far as, you know, importing data, Michael, that'll be for the younger tech guys, where I can send my grandkids up there and they can help.
Yeah.
There's 2 things I'd like to say. One of them is that you have the largest series in the world of sarcomas, and it's less than 150.
Yeah.
And I estimate that every year, if you take China and India, now that represents 3 billion people. Yeah. I suspect there's between 2,000 and 5,000 primary new sarcomas in the heart every year in a place like that.
Yeah.
Yeah. And, you know, even if we get 10% of that, even 10%, that represents a huge number. And and that's estimation based on what I see in Toronto and the catchment area of Toronto, my hospital. And those are the patients that actually get to me. And as you say, there are countless people that have an echo somewhere and they're told, I'm sorry, this is in your heart. And just like they used to say in the olden days, an affliction of the heart is a lethal infliction, and they were scared to touch the heart. It's the same thing with cardiac tumors, and that's what we're fighting. So we have no idea the number of places, and we have no idea even if there are places that are busier than yours but aren't publishing. And that's a really important thing.
Well, the other thing I'd point out, RJ and Michael, is that what I think is one of the biggest weaknesses of my database, I've just captured people I've operated on.
Right.
We have a lot more cardiac sarcomas that I see with Ravi and Bob Benjamin over at MD Anderson that we don't operate on for a variety of reasons, because we start them on chemotherapy and they get worse. And I think as we expand this out, we need to make sure we start to try to capture not just surgical patients, but every single patient. We really want a better idea, because if I have operated on them, I've selected a subset of people already.
Yeah, I'm the same way. I operate maybe 1 out of every 10 consults I get, if it's that high. The other thing I'd like to say is that really I would like this to get into the public, and a person who's in some remote place in Africa, I know there are people listening here from Africa, gets onto some sort of web-based thing and identifies themselves to us. And so we have to get to the grassroots levels at something like this. And I suspect you can do it these days way better than you could do it in the past, because everybody has a cell phone in their hand when they may not even have an x-ray in their hospital.
I probably get 4 calls a week with somebody sending me imaging on my cell phone, RJ.
Yeah.
Very common.
Yeah.
What we need is a central.
That as well. But Michael makes a very good point about capturing all of the patients with tumor as best we can. I think we should try to be population-based. And the way we can do that is work with the national societies of cardiology and cardiac surgery and oncology to make sure that we're capturing as many of the patients as possible within a region. You can imagine in a place like China, over 1 billion people, 1.5 billion people, it's going to be a challenge. But I think working with the national society and having their endorsement so that we don't have competing groups or competing registries, it would be very, very important. And each of our country and regional leads should have representation from the different jurisdictions, including oncology, surgery, cardiology, pediatrics, so on the committee, so that we're bringing everybody in. I think right from the beginning is essential.
We have the Seer Database, and Mike Seidman, do you know about that? I'm on their steering committee. I know a little bit about them. This is a group of pathologists around the world that define the tumors around the world and have a database for that. Michael, do you want to comment about
Several things have been written out of the Seer Database. We actually I wrote a paper recently with the group out of Boston using the national inpatient sample on sarcomas, which captures about 20% of the admissions in the U.S. Seer is very similar in how it captures patients. And there was just a recent paper, I think, written from the people at UPMC about this. That was a national study of sarcoma. So within the last year, there's been about 3 papers looking at national level sarcoma information. But even the Seer and the national inpatient sample capture probably only 20% of what's out there.
Yeah. I think that's we're not going to get everybody, but what we need to do is get as many as we can.
Well, I think the main thing is that the best time to start building this database would have been 20 years ago. The next best time is today.
Yeah.
And for those of us at the end of their career like I am, you're not going to be able to harvest it too much. But if we build this and keep it for 5 or 10 years, it is going to be not only great for our patients, but it is going to be a gold mine of academic work for young physicians.
Yeah, for sure. And it's not just in our specialty. It's going to be in oncology, radiology, pathology, everything.
I would say all the complex stuff that you and I do now, RJ, is becoming team-based.
Yeah, absolutely.